today. Let me just open this. I am going to share my screen quickly. Let me just see which one it is. Here we go. Okay, and then let me just see. Let me just start. Okay, let me just go in quickly. Hang on. All right. Just a moment. I'm just lining up here. Okay.
Recording in progress.
All right. Can everybody hear me clearly?
Yes.
All right. Sorry for the little glitch in technologies aside. All right. So good morning or good afternoon. I am Linda Veal. I'm a clinical specialist from Getinge, South Africa. And I normally work in Africa itself, but by chance I had the privilege of visiting your beautiful country in June this year. And I must say I came away with a very positive impression of the high quality of your healthcare in the country. Anybody who has met me know I can speak for hours on the top of balloon pump, and I'll try and keep it as relevant as possible for you. You're welcome to ask questions, maybe at the end of the presentation and so forth. I really am usually presenting on Teams. I'm not that familiar on Zoom. So without further ado, let's start. Okay. So we're going to look at a few things today. Is the timely evaluation of a patient response to treatment, especially cardiac patients, complications that you might incur with inotropes, mechanical support options, understanding the role of balloon pumps for cardiac patients, and a little bit of technological advancements and balloon catheters to optimize support. So before you look at shock, it can have many etiologies. The main causes are from acute myocardial infarction and acute and chronic heart failure. And it's a complex entity made up of a vicious cycle of injury, cardiac and systemic decompensation, further injury, and more decompensation. And you're experts on this already. But the one area that everybody agree upon is that early recognition and intervention is critical in interrupting the devastating shock spiral in any patients. I'm first going to touch briefly on acute MIS cardiogenic shock. This is something called the SCAI classification system that was done by a multidisciplinary group of experts led by the cardiovascular angiography intervention. And I created a simple classification to help better define the shock patient. And the goal was to create an easy way to remember and classify patients on presentation or during the hospital stages. So they use stages A, B, C, and D. And this was a common language to discuss the condition of the patient and was endorsed by several societies, both in the US and Europe. Briefly, stage A, patient at risk could be large MI, patient of pre-existing cardiovascular disease. B, the patient is just beginning with hypertension or tachycardia without hyperperfusion. And you think of the patient here you're worried about and want to keep an eye on. Stage C is the classic cardiogenic shock patient, hyperperfused, requiring intervention, vasoactive medications, and or use of mechanical support. And that they typically have lactic acidosis, poor urine output, cool chlamys periphery, and altered mentation. Then if you continue, stage D, deteriorating, and they fail to respond to current treatment. and they require even more support. And here I'm thinking about if you haven't started a balloon pump yet, you definitely should have started before. Maybe look at left ventricle offloading. You can even thought about, depending on the situation, on ECLS and so forth. And of course, extremis is the one you're looking at resuscitation circumstances. So once they published ICET, Jensen and his colleague looked at the validated classification scheme. So they performed a retrospective analysis of cardiac intensive care unit, and not, but admitted between 2007 and 2017 at a Mayo Clinic. And they looked at about 10,000 patients. Patients had shock from both acute MI and heart failure. What I found was mortality increased from 3% in stage A to 67% in stage E in the patient group, and the supported validity of the SCAI classification system for mortality risk certifications as a framework for future clinical practice and support. I had some takeaways from the study. The patients with stage C, classic shock, who responded to initial stabilization measures had a relatively more favorable prognosis. But a majority of patients included in the study most likely met criteria stage D. Together, the patients at stage A and B had about 70% of patients in the study, and this they identified it as a potential opportunity to initiate a safe, to initiate balloon pumps earlier, and so forth. Okay. This one briefly, acute heart failure shock. This you know very well, I'm sure, and you probably use additional classification systems. First, American Heart Association, and they looked at progressive stages, so forth, and actually, and then the New York Heart Association used to describe the degree of symptoms experienced by patients that range from mild to moderate to severe at risk, class 4. And then the symptoms were classified into consideration for mechanical support. And this was done by Intermax. I'm sure you also use your more specific levels and structures for your patient group. Quickly add the patient that can actually benefit from balloon pumps. That would be the cold and wet patients. Patients with congestion, poor peripheral perfusion, cold and wet pattern, they have inotropic drugs, diuretics indicated, they might require intensive care and escalation of therapy. Usually the mortality is 42% already. And the other one, cold and dry patients, are is more rare, but are sometimes managed by fluid administration depending on how the patient responds, but also mortality of 42%. So just to sum up here, the key for patients at risk and with hemodynamic compromise, rapidly identify them, initiate treatment early, evaluate quickly and often, and escalate to the next level of therapy if needed. Just took a few of the options for cardiac mechanical circulatory devices out there. First line is usually medical treatment, such as vasoactive medications, such as inotropes and vasopressors. Although good, these medications do cause an increase in contractility and heart rate and thus blood pressure, but they also contribute to increased workload on the heart. The mechanical circulatory support options include pulse counterpulsation, transvalvular pumps, and extracorporeal bypass pumps, which I'm sure you're very familiar with. Balloon pump therapy, I'm sure you're very familiar with. Insert femoral artery, the balloon sits in the ascending aorta, and it works in blood volume displacement principle. And by inflating, increase coronary perfusion, and by deflating, reduce afterload. And with the newest technology, the larger volume balloon catheters can provide up to 1.6 liters of cardiac output compared to the previous balloon catheters. If you look at transvalvular pump options since Impella, this can be percutaneously or through a surgical graft, depending on the size. They actually work on a propeller, ejects blood out from the left ventricle, provide continuous flow into aorta. So they unload the left ventricle and increase cardiac output. These devices are very good for offloading of left ventricle. An extracorporeal bypass pumps, tandem hearts also, as a left atrial to femoral artery bypass system, comprising a transeptal cannula, arterial cannula, and a centrifugal blood pump. And it can deliver rates up to 4 liters per minute at a maximum speed of 7,500 RPM. ECLS provides support for lungs and heart, and they actually remove the blood and return it, so forth. Oxygenate it itself. But I'm not going to delve too much in this. I'm not the expert on bypass, on ECLS and impellers myself. So let's just look at clinical evidence. So we looked at, previously I discussed acute decompensated heart failure. And this study looked at, Dr. De Van den Ill looked at the outcome of patients with decompensated heart failure and low output compared to use of balloon pumps with inotropes. And this study was small, 32 patients, but it showed a positive impact that a balloon pump has in multiple parameters, including increased diuresis, BNP reduction, increased cardiac power output. And this was also done with the larger balloon catheters, the 50 cc. So for those of you not familiar with those, if you want above 1.62 meters, you could normally take up to 40 cc balloon, but right now we've got a special balloon where people above 1.62 can take a 50 cc balloon. So looking at volume displacement principle, increase hemodynamic support, and increase coronary perfusion. The next study I'm looking at is the pharmacological treatment versus mechanical circulatory support. Okay, and they looked at mechanical support earlier instead of escalating doses of inotropes, and they found it might avoid downward spirals seen in patients with cardiogenic shock also. Then they further looked at the usefulness of balloon pumps, and the study was done in 2018. And it looked at the role of balloon pumps with cardiogenic shock, both acute coronary and non-acute coronary syndrome. They hypothesized that timely use of balloon pump in early stage of shock would improve outcomes, and the overall mortality was 36%. However, when a balloon pump was placed within the first hour of onset of shock, mortality was 24% and increased almost 50% in the latest stages of shock. And looking at also the number of inotropes itself, let me just put my laser pointer on. If you look at the number of inotropes, as you increase the number of inotropes, your mortality also goes up. So they are looking at incorporating a mechanical circular device such as balloon pumps earlier. And looking at earlier, they looked at the survival rate, 30-day survival rate when balloon pumps was placed within the first hour of onset of shock. And the survival rate went up to 76%, which is significant. And this was true for the both acute MIs and acute heart failure patients. The author's conclusion was, and it raised the questions, is it a device or timing and care surrounding the patient that makes the difference? A lot of studies still go on. So Impella has been making waves out there, and in recent observational studies comparing the outcome of intra-aortic balloon pump therapy with Impella or medical therapy, there has been a trend towards low mortality, low risk of bleeding complication, and lower risk rate with stroke rate of balloon pump. But I must admit, an Impella's ability to unload left ventricle is higher than the balloon pump itself, but it's different devices for different etiologies. This one is more, how can I say, applicable to you. They had a look at the use of balloon pumps pre-op, and they had a meta-analysis done on over 9,000 patients from 23 studies and from major databases. What I found was the pre-op support of balloon pumps reduces short-term mortality and the risk of post or below cardiac output syndrome. And significantly, they identified mortality and low cardiac output as one of the analysis positive outcomes. And they also defined high-risk patients as unstable patients, LM stenosis of more than of more than 70%, redo CABGs, history of AMI, and diabetes. All right, and they suggested to inserting balloon pump pre-op itself. Any questions so far, or are we still good?
Yeah, we're good.
Okay. All right. So let's look at, if you have a balloon pump at your disposal, how can you optimize it itself? Okay, this is just a synopsis of the benefits. So if we look at inflation, you create diastolic augmentation, can increase coronary perfusion, coronary blood flow, and increase myocardial oxygen supply. And that is usually seen as the white number on the side of the pump. And speaking to clinicians out there, they usually aim for above 100 millimeters mercury, or at least higher than unassisted systolic blood pressure. On deflation, the systolic unloading happens. So left ventricle wall tension and afterload is reduced, left ventricle end diastolic pressure is decreased, cardiac output is increased, and myocardial oxygen demand is decreased. But this is just a standard revision of what a balloon pump does. So what you want to see is increased coronary perfusion, cardiac output, depending on the intrinsic ability of the heart, especially the left ventricle. And something important to just remember is a balloon pump doesn't take over the function of the heart. It augments, it assists. If the heart muscle is so deteriorated that there's not much cardiac output itself, then there's a need for escalate therapy. You start with balloon pump and you escalate therapy further. If the heart muscle is not working, the balloon pump is not going to work. We actually work with the existing cardiac output with the patient. And these parameters are you quite familiar with itself. Okay. Important thing with the balloon pump is you need to synchronize with the cardiac cycle. So what we have information from the patient is their ECG and our arterial pressure waveform. ECG comes with ECG cables, and I always say keep the communication between the pump and the patient. Don't bring in a third party. There can be communication delays. And looking at arterial pressure waveforms, this is absolutely crucial for us. We can get it in two ways. We can do it through a more traditional way of a conventional balloon with connected to disposable transducer, like a fluid-based pressure reading, or we can get it through fiber optic fibers, which don't require a transducer. That's very fast and very accurate. And even for electrical surgeon interference, it's immune to it. So timing, we usually look where the balloon is inflated and where to deflate. And we look at the arterial waveform for that. Trigger, we look at an event that signifies the beginning of a cardiac cycle and to deflate the balloon. The question I get sometimes from clinicians or perfusionists in a hurry to initiate therapy is, I have a patient on the table, he's draped, now I need to start balloon pump. Can I start a pump without attaching the ECGs? And it is possible, it is not optimal, but it is possible. You can do that. Then the machine will from here, but as soon as possible, connect the ECG, at least the right arm, and left leg, at least. And you can put it in the back of the patient's, on the patient's back. I've seen people do this, especially if it's a fiber optic balloon itself. All right. One of the nice things about the new balloon pumps is the auto timing check. I grew up with balloon pumps when you had to manually do the inflation and deflation. You had to monitor this pump 24 hours a day. So I think it's very fortunate the new generation of people has got this automatic function itself. So sometimes you will have seen this happen maybe. You will look like the machine is running and all of a sudden it looks like it's skipping 2 beats. And this is just a U beat. For the machine updates, it's timing every 3 minutes to 2 minutes, depending on the type of trigger it is. And it lets you take this opportunity to look at the inflation point, pressure waveforms, diacritic notch, and so forth, to just adjust the timing itself, together with all the other software running at the background itself. So don't worry if you see this, the machine is working fine. The machine might postpone this if your blood pressure is too low. Then it will just say timing delayed or and so forth. Okay, now I'm just going to touch on this one. So this is what you want to see. The balloon inflate at a diacritic notch, and it looks at a sharp V. And typically we want this higher than anassisted systole. Like I said, some clinicians out there is aiming for 100 millimeters mercury or above itself. Secondly, deflation. We're going to compare end diastolic values, unassisted with the assisted. So you always want the assisted lower than the unassisted. So looking at this one, if you look at this, it's just a one complete cardiac cycle. This is the unassisted beat, okay? Unassisted systole, diastolic augmentation, assisted end diastolic pressure. Now, if you look at closely, the end diastolic pressure should be lower than an unassisted one. This is a sign of left ventricular offloading itself. And if you look at the unassisted systole with the assisted systole, you will see the assisted one is lower. Let me just see the previous slide, if I have that. Okay, this is 1-to-1 ratio. Normally, there's two sets of blood pressure values here. One mean value, but 2 systolics and 2 diastolics if you're in 1-to-2 ratio. Then you can clearly see numerically the difference between unassisted and assisted systoles and diastoles. That's a very nice way to look at it also. For me, it is very important to get clear information on your arterial pressure waveform and your ECG itself. The machine will swap between the different triggers itself to find the best possible source of information. But the quicker we can inflate the balloon and the longer we can safely keep the balloon inflated, the more support you can give. And this is where good signals, ECG, and a good arterial pressure waveform is very important. And looking at pumps, the pneumatic system on your CardioSafe is faster than the CS300 or old CS100s because it's a different compressor. Also, fiber optic signal, if you get an arterial pressure signal from there, it's faster, it's clearer. So the machine recognizes the opportunity to inflate earlier, and it can actually keep the balloon inflated for longer safely itself. And like I said, the new pneumatics can actually actively deflate the balloon very quick. So you have your optimal support during inflation. Fiber optics, I just touched on this. So we get a very reliable pressure waveform. Instantaneous signal transmission is 50 milliseconds faster than the normal ones. Faster time to therapy. So when you start off the balloon pump, literally you insert the balloon pump, you first switch on the balloon pump, check the battery and helium values. And as soon as you normally would then connect the ECG itself, but for you, if you insert a balloon catheter and you can't connect the ECG, just insert a fiber optic. As soon as it's in place, you connect the helium extenders to the machine, connect the fiber optic cable to the machine, and you press start. You don't have to zero nothing. What a machine does is it will actually zero inside the body and will continue to do that on its own automatically. And it's a very quick startup from there. And also very nice, this is immune to electrical surgical interference itself. Enough of that one. Okay, looking at the balloon catheters, like I said, you're going to try and give the patient the biggest balloon you can safely. And I made mention about the different balloons we have these days. I'm not quite sure which one you use, but let's look at our claim to fame here. So for 50 cc versus a 40 cc for patients above 1.62 and taller, you have 25% more blood volume displacement. Okay. when you insert a 50 in place of a 40, and an 18% more blood volume displacement if you insert a 40, where a patient could only get a 34 cc. And this, of course, improves unloading and augmentation itself. These are the sizes. So at the bottom two are the normal ones that you know. Normal regular size balloons, normal width, okay? So I'm 1.74 meters tall. I could normally get a 40 cc. But now I can go up to 50 cc on these special ones safely. Of course, there's two types. The mega is non-fiber optic. That is the bigger cousin of the linear. And the Sensation Plus is the bigger cousin of the Sensation. That's fiber optic balloons itself. But that is my claim, okay? But let's look at the data also. And one of the questions I get is, now you made the balloons wider. How big is wide? So even the biggest 50 cc balloon, widest diameter, is 17.4 millimeters in diameter in aorta. And that's an additional 2.4 millimeters. So that allows us to increase the volume from 40 to 50 in itself, and it's 8 French catheter, right? The 40 cc balloon catheter is normally 16 millimeters and is 1 millimeter bigger than the other one, and so forth. Not much difference, and lengthwise, not much difference itself. Okay, so there's kind of 3 studies I'm briefly going to touch on here. Is they had a look at these bigger balloons that we claim is so good, and they went and tested it. The first one was Kapoor, and he looked at 52 patients itself. Okay, and what he found was he had data before activation and after activation itself. So he looked at 40 cc's versus the 50 cc's itself. All right, then he had cardiac index, cardiac output, PI diastolic pressure, and so forth. And if I can just make a synopsis here, within 24 hours of the balloon activation, now remember, a balloon usually starts working within 15 minutes to 30 minutes. If it doesn't work by then, you need to escalate. You found there was a definite decrease in PA diastolic and occlusion pressures. The cardiac output and index was increased. The saturation, PA saturation increased. They had an absolute change in cardiac output with the 50 cc versus 40 cc with a 1.4 liters or 40% absolute difference in the cardiac output versus only 18% or 0.7 liters per minute for the catheter itself. Now, I think earlier I mentioned 1.6 liters these days, the extra to the heart's own intrinsic ability. The second one was VISVERUS 1. Also looked at the primary outcomes for renal function and survival discharge. And he also looked at the same parameters. And he showed even greater response. He had a 66% rate of survival to hospital discharge. After 50 cc balloons were used itself. We do talk about the super responders and balloon catheters also. So I think he had some of those in his study. Third one is Baran, and he looked at the previous studies and a total of 76 patients and so forth. And I'm just going to give you the bit of a synopsis now here. And I spoke about a patient, how they can respond to any given treatment, and it can vary, okay? And this demonstrated that most patients did respond positively to the therapy, and the average improvement in cardiac output is 1.6 liters, and cardiac index 0.8 liters per minute per square meter. And particularly the patient who have the most significance to those bigger balloons was those with the lower cardiac output and cardiac power index, along with elevated right atrial and pulmonary artery diastolic pressures. In addition, the magnitude of the response was higher than previously reported with smaller balloon catheters, but it did not lead to a difference mortality survival discharge of 72%. The other major finding of the study is that simply improving cardiac output does not correlate with ultimate outcome, okay? So they were still looking at continuous studies and so forth itself, but a significant if you look at a synopsis of the three studies itself, cardiac output and cardiac index, all of them showed a significant increase on those parameters itself, which I think would be good for patient outcomes. Now, the bigger balloons, we look at the safety. So it also have a low safe incidence complications. Bleeding requiring transfusion 3.3%, which is low. Major vascular complications 0.7%, and minor complications 2% itself. So although it's bigger, it doesn't have such a negative effect on side effects or complications. The 50 cc is an 8 French catheter. And if you compare that to our smallest catheters, a 7 French, that's our sensation. And regular balloons like the linear is a 7.5 French itself. All right. Lastly, I just want to show you that there is online resources that you can go as a clinician or end user, go and watch at your own time. And you can also watch videos from across the world on various topics, not just balloon pump, but itself. You can actually subscribe to what you want to see from there. Thank you very much, and you're welcome to ask me questions if you wish.
Thank you very much, Mrs. Bell. Very interesting lecture and very informative.
Your sound is not clear, Badia.
Hello. Yes, thank you, Mrs. Vale, for your lecture. Very informative. Any question from the audience?
So before you conclude, I'd like to thank you, Linda. This is Dr. Kogir. I send you your card to Dr. Luai so they can make this arrangement. And thank you so much for this illustrative talk. Thank you.
Thank you very much for the opportunity. I wish to see you again someday. You never know. Okay.
All right. Thank you again. Yes, go ahead.
Sorry, I think I will leave you then to the rest of your presentations as a group, and have a pleasant afternoon.
All right, you too. Well, we thank you again, and we'll take a 5-minute break, and then Dr. Ahmed, if you, in the meantime, prepare your slides. We'll resume with another presentation titled SAM. We have a guest consultant, Dr. Maya Shahid, cardiologist from King Faisal Specialist Hospital. We'll be resuming our activity in 5 minutes. Thank you.
Recording stopped.
Okay, Dr. Ahmed, whenever you're ready.
I'm just waiting for Dr. May.
Sure. Take your time.
Thank you. اوكي السلام عليكم، الصوت واضح؟
أحمد it is واضح.
Okay. First, I would like to thank Dr. May, consultant echocardiography, cardiology, for joining us today. So my presentation today is about systolic anterior motion. So as introduction, systolic anterior motion, it describes the dynamic movement of the mitral valve during systole during systole anteriorly toward the left ventricle outflow tract. Also can be defined as a systolic displacement of the distal portion of anterior leaflet of mitral valve toward the outflow tract, or less commonly the chordae. So SAM was first documented by Termini 3 decades ago and was initially considered to be specific to hypertrophic cardiomyopathy. Now it's recognized to arise in any setting that alter the complex dynamic anatomy of the left ventricle. So early reports identified the LVOT obstruction to occur in all cases of SAM. It's now understood that its presentation can vary from clinically silent disease to severe LVOTO with the associated hemodynamic compromise. In order to accurately address SAM, it's necessary to characterize it, to characterize its severity and understand its anatomical basis. So stepwise management protocol can then be initiated, ranging from conservative approach of ventricular loading, vasoconstriction, beta blocker, to definitive surgical correction. So moving to the pathoanatomical mechanism of systolic anterior motion, SAM pathology is not fully understood. The mitral valve consists of anterior and posterior leaflet, annulus, and the subvalvular apparatus of papillary muscle and the chordae tendineae. The function of mitral valve is dependent on these structures also, along with the left ventricular structural and contractility. So changes in any element can predispose to SAM. So the role of mitral valve leaflet in SAM, excessive anterior or posterior leaflet tissue can predispose to SAM because they provide the large surface area in which drag forces acts, drawing the mitral valve anteriorly and toward the left ventricle. They may also cause mitral valve coaptation point to move anteriorly toward the LVOT. It was thought that Venturi effect from the septal hypertrophy, sucking the mitral valve leaflet to the LVOT alone, could account for SAM. But now it's recognized that also drag forces also thought to play a role. It has been proposed that Venturi effect may elevate the mitral valve and the drag forces may move it anteriorly, resulting in synergistic mechanism to result in SAM.
One is for you.
Dr. Omay?
I am with you, sorry. I'll unmute, sorry.
Okay, sure. So these echo pictures will show the, this is a transesophageal echo of the leaflet motion during the SAM. So as we can see in picture number 1 and 2, at early systolic phase, the mitral valve close and the leaflets coapting together. And picture number 3, the tip of the anterior leaflet moves anteriorly toward the ventricular septum. So after that, number 4, the residual anterior leaflet become beyond the coaptation point, sucked into the LVOT. And in this one, number 5, when the left ventricle began to eject, the residual anterior leaflet was forced by the ejected blood. And in picture number 6, the mitral leaflet non-coapted and displaced anteriorly, obstructing the LVOT, resulting in severe mitral regurg and high pressure gradient in the left ventricular outflow tract. So also this picture, transthoracic echo, we can see here in a diastole where the mitral valve is open, then early systole where the mitral valve closed. So after that, in the, I would say mid systole, we can see the anterior mitral leaflet sucked or directed toward the LVOT. And in this picture, we can see the complete obstruction of the LVOT by the anterior mitral valve leaflet. So to continue the role of the mitral valve leaflets in SAM, changes to the posterior leaflet height have been proposed also to be an important as its result in the anterior shifting of the coaptation point, predisposing, pushing the anterior mitral leaflet and predisposing to SAM. So recent clinical studies associated with, clinical studies associate the insertion of rigid and semi-rigid mitral rings with the disruption of the anterior mitral annulus dynamics. So patients with mitral rings can demonstrate gross disruption of the LVOT function on cardiac MRI. And there is increasing evidence that identifies disruption of the mitral annulus and aortic root dynamics as the primary cause of SAM after mitral valve repair using leaflet resection and rigid rings. So moving to the role of the mitral annulus in SAM, this is supported by the evidence of large series of patients who underwent mitral valve annulus. So the subject did not receive leaflet resection and were not given oversized rings. And the result demonstrates successful postoperative mitral dynamics. So SAM is normally prevented by the early systolic expansion of the aortic root and the flattening of the aorto mitral angle that displays the anterior mitral forward and backward to the left atrium. Annular undersizing is a risk factor as it promotes the bludgeoning of the leaflet tissue and reduction in the annular circumference reduce the mitral mitral angle, which increase the risk of SAM. So annuloplasty ring size must be selected according to the risk of SAM, with large rings used in patients with high risk of SAM. Moving to the role of subvalvular apparatus. So of coaptation zone, this results in SAM. This is, there is growing evidence that SAM is associated with caudal as elongation. Any pathology that can cause caudal elongation can be exposed to SAM. Also, post-surgical intervention on the chordae, such reimplantation, also may result in SAM. So SAM of the chordae themselves can also occur in patients presenting for echo, for cardiac or even non-cardiac disease. And still its pathology, it's not fully understood. And the for papillary muscle have special importance in the asymmetric ventricular hypertrophy, where the anterior and the medial displacement of the papillary muscle significantly influence SAM. Also, SAM can happen post-aortic valve replacement. So post-AVR, SAM should be considered in the context of pre-existing aortic stenosis, where increased blood velocity in the LVOT cause drag force to the anterior mitral leaflet that result in SAM. So this compounded by hypertrophic and small LV cavity due to the aortic stenosis found in such patient. So after surgery, reduction in the afterload may cause mitral valve to move closer to the LVOT. So moving to the imaging modalities and risk assessment of systolic anterior motion. The risk assessment using imaging modalities continue to evolve, but depends on careful echocardiographic assessment, which should always be performed on closed ventricle. So traditional two-dimensional echo is useful in confirming the presence of SAM and assessing the LVOT gradient, as it may point to a clear and gross anatomical cause. Also, transesophageal echocardiography will provide clearer images. MRI will provide the best imaging modality to decide on possible anatomical causes of SAM, including anomalies of the leaflets, chordae, and the septum. So there are a number of structural and geometric factors for SAM which should be assessed. The most important are the annular circumference, distance between the coaptation point and the septum, left ventricular outflow tract gradient, and general assessment of the left ventricle and leaflet morphology. So moving to the management of systolic anterior motion. So the correct management of SAM depends on two factors: the anatomical lesion responsible and the degree of the severity. So to start with the medical management, it focuses on the filling of the left ventricle in order to move the mitral valve apparatus posteriorly and away from the septum. So generally it consists of three things: optimizing the LV filling. So you will give volume and you will maintain the slow heart rate. Also, you will decrease the LV contractility. You will discontinue the inotropic support, and you will consider beta blockers. This also will help to, it will give time to the left ventricle to fill with blood, and this will help to push the mitral valve away from the LVOT. Also increase afterload with norepinephrine or vasopressin. You will maintain high MAP above 70, 75. This also will help to or move the mitral valve away from the LVOT. So in this study, systolic motion after mitral valve repair, a surgical intervention necessary. So in this study, they assessed the effectiveness of the medical therapy in 174 cases of SAM, raising a cohort of 2,067 patients. They report that medical therapy was sufficient to correct SAM in the majority of patients, and only 4 patients require reoperation for SAM. And at late follow-up, SAM persists only in 17 patients. These results suggest that medical therapy alone may be sufficient for mild SAM, but surgical therapy remains the definitive therapy for severe degree of SAM. So systemic approach for the management of intraoperative post-MV repair. SAM has been proposed as a stepwise approach consisting of conservative management, first, then surgery, if failed medical management. So they studied that a total of 9.8% of patients in their series of 608 patients had SAM, and less than 1% of patients had a persistent SAM requiring reoperation. So moving to the prevention part. So in order to prevent, we need to know the risk factors. So we have major and minor risk factors for SAM. The major is excessive valvular tissue and undersized annuloplasty. And the minor factors, which is the narrow aortomitral angle, hyperkinetic, small ventricle, septum bludgeoning, and abnormal configuration of the anterior leaflet. So Shah used the transfusion echo to identify a high aortomitral leaflet and a small annulus to be the characteristic of patients with SAM. So the anterior mitral leaflet and the annular dimension appear to have marked mismatch in patients with SAM. Therefore, they proposed that the choice of annular ring size should take into account the anterior mitral leaflet height, as the anterior mitral height was the most important determinant in the study of SAM. This work supports the use of anterior valvoplasty. So you will do an elliptical excision of the anterior mitral leaflet to prevent SAM, and the maximum size of elliptical excision to be done in order to reduce the height of anterior mitral leaflet. So this excision site then closed with the double layer Prolene stitch, and then mitral valve repair will continue as normal. Also, others, they report the outcome of this technique in 47 patients and showed that there was no post-operative SAM. Also, he showed that a significant reduction in the anterior posterior mitral leaflet ratio and the distance between the coaptation point and the annulus. Lee used the transesophageal agents, pre and post SAM correction, pre and post SAM correction, who developed SAM post MV repair, and they showed that during SAM, large posterior mitral leaflet could result in a relatively more anterior coaptation line, and used this to suggest that posterior leaflet sliding plasty could eliminate SAM. This technique was developed in 1988 by Carpentier and reduces the height of posterior leaflet. The middle posterior segment is most commonly implicated, and if confirmed by intraoperative inspection and transesophageal echo, then slidingoplasty is performed. So when mitral valve replacement can be used as a treatment of systolic anterior motion. So SAM is not a benign condition, and the LVOTO can be fatal consequences. Mitral valve repair is superior to the replacement, replacement, especially for younger and female patients. And mitral valve replacement has a very small role in the modern management of systolic anterior motion. So if SAM persists despite medical and surgical attempts, mitral valve replacement can be done. And the decision to opt for replacement depends on the chances of eliminating SAM by repairing or re-repairing the mitral valve. Systolic anterior motion in hypertrophic cardiomyopathy, the incidence is in patients with hypertrophic cardiomyopathy is almost 30 to 60%. And after mitral valve repair is almost up to 16%. So the mechanism of systolic anterior motion in hypertrophic cardiomyopathy, so congenital papillary anomalies, displacement of the leaflet, and leaflet elongation associated with hypertrophy can contribute to SAM. So in hypertrophic cardiomyopathy, the anterior displacement of the papillary muscle mitral valve leaflet into the LVOT. Also, septal hypertrophy observed in patients with HOCM create large drag force and promote Venturi effect, which can move the mitral valve anteriorly, resulting in SAM. Also, the dimensions of the left ventricular outflow tract lowers the threshold of the SAM. So echo in patients with hypertrophic cardiomyopathy. Systolic anterior motion may arise due to a number of causes, and a combination of these causes include leaflet pathology, chordae anomalies, and the septum. So Spirito assessed the SAM etiology in 62 patients with hypertrophic cardiomyopathy, and they showed that 85% of patients, both leaflets play a role in SAM, and almost 30%, the posterior leaflet was involved alone, was the responsible, and 10% only was the anterior leaflet was responsible for SAM. And they found 1% of patients SAM was attributable to anomaly of the chordae tendineae. So SAM arise in hypertrophic cardiomyopathy due to septal hypertrophy, which increase the drag force acting with the mitral valve, also due to a primary mitral valve anomalies. So septal myectomy is the primary approach in patients with hypertrophic cardiomyopathy, as it increased the distance between the anterior mitral valve leaflet and the septum, and also reduced the LVOT obstruction. So in conclusion, systolic anterior motion can be life-threatening condition And SAM can result in severe left ventricular outflow tract obstruction, and or mitral regurgitation is associated with up to 20% risk of sudden death. Its mechanisms are not fully understood, but include pathoanatomical dysfunction related to the mitral valve and its apparatus. It's classically observed, SAM is classically observed in patients with hypertrophic cardiomyopathy or after mitral valve surgery, but can occur in normal. The current diagnosis of SAM is based on detailed echocardiography or MRI, and its subsequent management requires stepwise approach, initial medical management to eventual surgery as the last option. Finally, further research is necessary to clarify diagnostic and treatment strategies for SAM, and understanding the mechanism of this disorder may provide future therapeutic options. So by this, I conclude my presentation, and thank you so much. Any comment, Dr. Omid?
Yes, Ahmed. I wouldn't mind at all. Thank you very, very much for a very beautiful talk, illustrating the issue of SAM. Can you hear me well? I hear a lot of.
Yes,
Are
Dr.
we okay? Excellent.
Yes, Dr.
I think let's just really illustrate.
Dr. Amay, there is an echo sound.
That's what I'm thinking. I'm trying
Yeah.
to find out where is it coming from.
Maybe you are opening another one, that's why.
I haven't opened it, no. At least now when I'm talking to you, there is nothing now. Am I right?
No, yeah, there is nothing now, yeah.
Okay.
Great.
Good. Let's illustrate something very important. Number one, I asked Ahmed to ask you a specific question. When do you think, by the way, you are surgeons, and most of this occurs, frankly, in relation to surgery is after mitral valve repair for mitral valve prolapse, okay? And this is the main thing that we as echocardiographers face. And I think the most important thing to remember is that Ahmed illustrated really, really beautifully what are the things that should prepare us to prevent this thing. And remember the morphology, the excessive tissue of the valves, the elongated chordae, all of these can be picked by echo, both by transthoracic and transesophageal echo, to prepare us. Of course, MRI, I'm not an MRI person, and I'm sure MRI can definitely show all of these things to prepare the surgeon for this condition, which is SAM after the repair. Now, the question is, I don't know if one of you would like to answer. You are a surgeon, you did a very good job, you repaired a very sort of in a case with mitral valve prolapse, and then you want to assess the result of your work. You ask an echocardiographer to come and assess. And the echocardiographer comes and assesses the result of your work. And what is the first thing that will make both of them, the echocardiographer and the surgeon, seeing it, get worried and start looking for SAM? Could you guess? Something very straightforward. Who would like to answer that? Tasneem, are you there?
Yes.
Yes. So what is the thing? You've seen few cases with me in the last week or so. What is the first thing that attracts your attention?
If there is in the echo, you mean?
In the echo, in the transesophageal echo, where we start jumping up and down, you know.
Yeah, if there is low volume.
No. I think, yes, you are right. We would like to know about the size of the, but you know what's the first thing that we see and tell the surgeon? We tell him you did a
Mitral.
very, sorry?
Mitral regurg.
Mitral regurg. Excellent, excellent. Surprisingly, some of them will even have more mitral regurg than what they started with. And that's when, you know, you have good surgeons and you know that something is expected to happen with the repair of mitral valve prolapse. That's when you start looking for SAM in all the proper views, and that's when you pick it. So the first thing that attracts attention is the mitral regurgitation, and then you find the SAM. And I think medical management should always be the first thing that comes to happen, and that nothing is more beautiful than the sort of cooperation between the surgeon, the echo person, and the anesthetist to deal with this problem. And remember, everything Ahmed told you, the most important thing, we don't want a small ventricle due to any cause, and we don't want a very well contracting ventricle, because both of these things are gonna cause more anterior motion of the leaflet and cause more obstruction and cause more mitral regurgitation. So please fill the heart with the help of the anesthetist. Next, stop inotropes if you can do it, and most of the time the left ventricle is good, so you can do it, so that you don't make the ventricle contract better and cause obstruction of the LVOT. And the third thing, give a short-acting IV beta blocker. Esmolol is what is usually used, so that with the negative effect of the beta blocker on the contraction of the LV, you also you relieve the obstruction of the LVOT. So make the ventricle bigger by the fluids, and prevent smaller ventricles by the beta blocker and by stopping inotropes. And I've seen myself around 7 or 8 cases of SAM, and in every single one of them, except in 2 cases, the medical management helped a lot in relieving the SAM. And of course, you send them home on a beta blocker for some time, so that the ventricle is given the chance to remodel and become okay, and then you can stop it. And it's only 2 who had to go for surgery for sort of refining the repair. I remember one case, the surgeon opted to shorten the anterior mitral leaflet. So in summary, it's a condition that can be prevented by looking very carefully at the mitral valve morphology, at the annulus, at the direction, or the way the leaflets meet, so that you can prepare for it. Look at how much excessive tissue you are. When you see mitral regurgitation after you do a repair, look for SAM and then manage it medically. If anybody has a question, I am more than willing and happy to answer. Okay, Ahmed, I think you have given the message very well to your colleagues.
Thank you so much, Dr. May.
Very well done. Thank you.
Okay, so I will conclude here. Thank
Okay,
you.
thank you.
So I will conclude here. Thank you.
Thank you, Dr. Ahmed. Thank you, Dr. May, for your joining us today. Thank you, Ahmed. Very informative lecture. With this, I think we conclude our topics for today. So this is a wrap. Thank you very much. Thank you all for coming.
Thank you.
Thank you.
Thank you.